Good afternoon. My name is Courtney Allen, and I am a second-year Pediatric Emergency Medicine Fellow. And today we're going to be talking about pediatric head injuries, to CT or not to CT. Pediatric head injuries are a pretty common chief complaint that kids come in to the ER with. And when they do, we as their physicians have to decide whether or not the injury was serious enough to warrant sending them to the CT scanner. So how do we do that? In the emergency department, we use something called the PECARN criteria to help guide us in the decision whether to CT or not to CT. PECARN study for head injury was actually a paper or a prospective cohort study published in 2009 by PECARN, which is the Pediatric Emergency Care Applied Research Network. And this study aimed at identifying children at very low risk of clinically important brain injuries after head trauma. This study actually looked at a little over 42,000 children, obtaining CTs on almost 15,000 of them. And from this, they were able to identify clinically important TBIs in 376 of those children. From this study, they were able to make a set of prediction rules, which we use to help us determine when to CT children or when we can observe them without a CT scan. So what are the criteria that we look for? This is just, again, that study that I was just talking about from the Pediatric Emergency Care Applied Research Network. So the PECARN criteria is actually divided into children younger than 2 and children over than 2. So the first thing that you need to look at when kids come into the emergency room with a head trauma is right here highlighted in green, is their GCS less than, or blue, sorry, is their GCS less than 15? Do they have a palpable skull fracture, or do they have any ultramental status? Agitation, slow response, repetitive questioning, a little hard and younger than 2, but that's the criteria. If they do, do not stop, go, we're going to the CT scanner. But if they don't, we have some more questions to ask. In a child less than 2, on your physical exam, do they have a scalp hematoma? Do they have loss of consciousness more than 5 seconds? Not acting normally per the parent, or you always have to ask about the mechanism of injury. Did they fall more than 3 feet? Was it a was it a MVA with ejection, fatality in the car, or rollover, or even the other car? Was it any sort of peds versus bike or auto, and any sort of high impact injury? If you said no to these, then you can observe them and have confidence that you have a low risk, less than 0.02% likelihood of having a clinically important TBI. If you said yes to any of those, then you really have the decision to make, observing versus CT. And in the emergency department, those clinical factors, do you have multiple factors or do you have one? You can observe them, and if anything changes during the ED course, like they have ultramental status, worsening headache, or vomiting, then you can always proceed to the CT. I think really important too is less than 3 months of age, most likely they're going to need a CT if you are worried about possible head injury. In children older than 2, very similar criteria, but the questioning that you may do in the ER is just a little bit different. Again, here in that green box that I'm highlighting, GCS less than 15, GCS less than 15, signs of a basilar skull fracture, or ultramental status. If you're saying yes to that, we're going to CT. If you're saying no, then you need to ask your questioning, your line of questioning that we talked about before as I'm highlighting them. Vomiting, loss of consciousness, severe headaches, or severe mechanism of injury. Important to note that in older than 2, your fall is going to need to be more than 5 feet. But again, those same mechanism of injury questions. If you say no to these and you decide, if you have no to all of this questioning, then your risk of a head injury is less than 0.05% for that clinically important TBI. Again, same as in less than 2, if you have any of these symptoms on exam or in questioning, you have to make that decision whether you're going to observe, excuse me, or send to the CT scanner in the emergency department. So just to recap really quick, first thing you're going to do when a child comes into the ER, you're going to ask them, find out 3 simple things: GCS less than 15, palpable skull fracture, or signs of a basilar skull fracture. If they're over 2, an ultramental status. If your patient has any of those signs when coming into the ER, you are going to do very important thing. You're going to CT scan that patient. If they do not, please proceed to your questioning. This is, again, older than 2. Vomiting, loss of consciousness, severe headaches, mechanism of injury. Less than 2, the loss of consciousness is for more than 5 minutes. Oops, sorry, pushed the wrong button. And if you said no to those, you can probably observe without any sort of CT scan. And if you said yes, you have the decision whether you are going to sorry, trying to get the right pen color, observe or CT. So the important decisions to make when a kid comes into the emergency department with a head injury. But luckily, this PCARN study is able to give us some helpful guidelines if you've run into that situation. These aren't hard and fast rules. If you think that a kid doesn't look right, even if they don't meet the initial criteria, then you need to do what's clinically best for the patient. Just wanted to thank you all for listening to my quick review on our PCARN head injury prediction rules, and I hope you guys have a happy holidays. All right, bye-bye.